Okay, I think I'm going to stand over here, actually. Yeah, it's a bit better. It's very tall. Okay, so hi, I'm Ed Wallet. Just a quick show of hands. I know you're all first and second years. Can you put your hand up if you're in the first year? Of course, yeah. And second years? Good, so the majority of people are just about to sit their intermediate MB, is that right? Good, so this will be pitched exactly the right level. Okay, so currently I'm an F2 doctor. I'm Chelsea Westminster. For my sins, currently doing accident and emergency. I was trained at Imperial, graduated 2008, and I set up the site podmedics.com. Another quick poll, who, apart from having received an email that someone from Podmedics was coming, who's ever been to the website before and knows about Podmedics? Good. Good, 50%. So that means the other 50% will have an opportunity to see it. So what am I going to do? I'm going to talk about all of endocrinology in the next 2.5 hours. Basically, I want to divide it up 2 bits. In the first session, I want to talk about difficult stuff to do with the pituitary, steroid disease, and diabetes. I'm not going to do the thyroid because I believe you've had quite a lot of that quite recently, and also it just wouldn't fit in with the rest of the stuff. And then in the final half, what I want to talk about is electrolytes and fluids and things. Now, I know this is actually on your syllabus. Kat kindly forwarded me a copy of the syllabus. But what I want to do is probably go through it in a way that you probably haven't heard before. And I want to try and make it a bit more relevant, not only to what you're going to see in the intermediate MB, but also what you're going to encounter when you move into sort of the clinical world, and indeed that place which you're probably all looking forward to immensely, day one on the wards. So you might have wondered what this thing is attached to me. This is being recorded live at the moment on here, and everything that I say with the slides will be up on the website for everyone to see, download, do what they want with later on. And this is just, we do Podmedics Live here, which is just when I go lots of different unis and do these talks. So, and that's the website. So let's start off with pituitary disease. So this is just a reminder. It is, whenever you're approaching any sort of topic in medicine, when taking pituitary disease, steroid disease, diabetes, you don't need to go back and know everything about the physiology of that system or the anatomy of that system, but often there are aspects of it that are useful to know when you consider clinical things. So what I want to do is just go through the basics here. Obviously, your pituitary, you've got 2 bits, the anterior bit where most of the hormones come from, and the posterior bit where 2 hormones come from. And then they're connected to the hypothalamus up here by a pituitary stalk. And then, importantly, the anterior hormones that you see produced are TSH, prolactin, ACTH, GH, FSH, LH. Now, that's a list. I don't really go for learning lists, but that is a list of things that I do recommend you learn. You know that there are those 6 hormones produced there from the anterior side. And the posterior side, it's really easy. There's only 2. You've got ADH and oxytocin. Now, in terms of relevant structures that are nearby, this is absolutely the one you need to know about, this optic chiasm. Okay, and that just puts it into perspective. So that's basically all you need to know about the pituitary when it comes to what can go wrong with the pituitary. So if we look at pituitary disease, there are 2, when things go wrong with the pituitary, when disease happens, there are 2 things that happen. You get problems with those hormones that are produced, and you get problems from disease itself within the pituitary, causing a mass effect on the surrounding bits and pieces, because obviously it's quite an enclosed space around there. So, as with most things, medicine's really easy. Hormone effect, you've either got too much of something or you've got not enough. So, in the case too much, you've got hyperpituitarism. That kind of makes sense. Actually, that's quite rare. And you've got hypopituitarism, or not enough of something. That's very common. Under mass effects, any space-occupying lesion in the brain, whether it's in the cerebellum, whether it's in the frontal lobes, or whether it's indeed in the pituitary, causes features of a space-occupying lesion within the brain. So that's your typical thing for your EMQs, you know, headaches, morning headaches, vomiting, that kind of thing. All red flags that there might be a tumor. The optic chiasm, this is where this comes in. Okay? Anything in the pituitary that grows big can compress the optic chiasm, as we saw on that initial diagram. And if that happens, you get this particular type of field defect called a bitemporal hemianopia. That's basically when you lose that bit of your vision. And then finally, if I didn't show it on the other diagram, but if the thing gets really big, it can go into the cavernous sinuses. And if that happens, you can get involvement of these 3 nerves, 3, 4, 6. If you're familiar with your cranial nerves, those are the ones that are really important in maintaining eye movements. And if your eyes aren't moving properly, then one eye sees something that the other eye doesn't, and you get double vision or diplopia. Okay, so that's really just a simple overview of what can happen when things go wrong in the pituitary. So what's the most common thing that goes wrong? Well, a tumour, usually a benign tumour or an adenoma. Now, there are 2 basic types, which are pretty much alluded to by my previous slide. Non-functional ones that don't produce any hormones are actually very, very common. And usually they're microadenomas, which, if you remember from your pathology, means they're less than 1 centimetre. Macro ones are greater than 3 centimetres. But usually they don't cause any problems. And then you've got functional ones that tend to produce hormones. And they nearly always tend to be small. So they're nearly always microadenomas, less than 1 centimetre. And these are the 3 hormones that mainly, if they're going to produce hormones, that they do produce. You'll read about in books that any hormone can be produced, but in reality you won't see that kind of thing. What you will see and expected to be familiar with from a sort of clinical syndromic point of view is the syndromes you get when these 3 hormones are produced. So that's what I'm going to focus on. So if you have one that produces prolactin, we call that a prolactinoma. Oma, tumor, prolactin, easy. There are 2 different categories of presentation that make sense if you know about the hormones. On the one hand, you've got people who do not have any sort of menstrual cycle. So men, hopefully, and postmenopausal women. So the problem here is that they actually don't cause many symptoms. It's very insidious. It's sort of, you get non-specific presentations. You may get some of that headache, some of those headachy features, early morning headache, etc. You may, if the tumor gets big enough, even get a bit of bitemporal hemianopia or cranial nerve palsy, 3, 4, and 6. But usually these things present quite late. However, in people who are, in women in other words, who are maintaining a menstrual cycle, you get direct stimulation of lactation caused by prolactin. And also, because of the effect that prolactin has on gonadotrophin-releasing hormone, you get alterations in all the levels of FSH, LH, gonadotrophin-releasing hormone that causes menstrual cycle disturbance. Okay, so in an EMQ, if you had someone who came in, 22-year-old girl, she had early morning headaches with some vomiting and some menstrual cycle disturbance, could be a prolactinoma. And these obviously present early because the problem starts with the onset of menstruation if the disease is there. So, what do we do about it? Management. Well, we need to diagnose that it's there. Obviously, the easiest thing to do is to MRI the head, but we can't MRI everybody's head who comes in with those symptoms. So we tend to just measure a basal prolactin level. And most of the time, although it's not 100%, that picks up an elevation in the level, and then an MRI has gone on to be done, and they find a tumor. In terms of treatment, just because there's a tumor there doesn't necessarily mean that you have to run in and take it out with surgery. In fact, the first-line treatment is always to use a dopamine agonist, as that reduces the amount of prolactin that's produced. And the 2 ones that you probably need to be familiar with are these ones, bromocriptine and cabergoline. If that fails, so if drug therapy fails to control the symptoms, and some people actually get very bad side effects from those drugs, or if the thing gets so big that it causes one of those mass effects like bitemporal hemianopia, diplopia, then often you do have to go in and do surgery, and you do it through the transsphenoidal route. So you do surgery through the nose up into the sphenoidal space. However, obviously, there are side effects associated with that. One of them is recurrence. For some reason, you can take out bits of prolactinoma, but it does come back. And then the other one, of course, is you render that person hypopituitarist because you basically destroy their pituitary gland. Okay, so that's prolactinomas. Any questions about prolactinomas? Yes? probably not to the same degree. Because the problem is if you're on the sort of estrogen or progesterone-containing compound, you're relying less on your LH and your FSH because those things are suppressed anyway, because that's what you want with the pill. So yes, I would think they would probably be masked. And that's a very good point because so many young women, of course, now are on some form of contraceptive. Definitely, yeah. Oh, let's go back. So, any others? No? Good, let's go. So, the next commonest, the ones that secrete growth hormone. Okay, now, bit of physiology, growth hormone acts mainly on the soft tissues, causing growth, and acts via this insulin-like growth factor 1 compound. Now, the clinical features depend mostly upon the age. So in kids, you get this gigantism. Okay, so I'm sure you've all seen these really tall, often Chinese basketball players who are sort of 7.5 foot. A lot of them have gigantism, that's why. In adults, they get this thing called acromegaly, which has a specific set of cosmetic features. And it's one of the sort of pictures that you should be able to instantly recognize and go, aha, that's acromegaly. That's caused by a growth hormone secreting adenoma. And they also get systemic disease as well, because alterations in IGF-1 cause multi-system derangement in things such as glucose and the way that lipids are laid down, accelerates atherosclerosis, that kind of thing. And this is the typical thing you need to be able to recognize. These really typical facial changes, thick skin and lips, frontal bossing up here, mandibular protrusion, big hands. Now, they always stand like this. The other way, you're not very good with faces. If you ever see anybody standing like this in a medical context, it'll be because they have acromegaly, because they want to show the hands and the features on the hands. And the sort of 3 systemic things to remember with acromegaly are 1, carpal tunnel syndrome, which happens because if you think about it, lots and lots of soft tissue swelling around the wrists. Your median nerve is the thing that's compressed in carpal tunnel. If that gets compressed by the swelling, carpal tunnel. Diabetes, they nearly always get diabetes, and accelerated atherogenesis. They usually die of heart attacks. Okay, so management, once again, just the very basics. How do we diagnose acromegaly? How do we treat acromegaly? Now, you can do a serum IGF-1. That makes sense, obviously, because lots of growth hormone, lots of IGF-1. Unfortunately, 25% who do have a raised growth hormone level will not have a raised serum IGF-1. Don't ask me why, but that's just what happens. So the gold standard is this thing, the oral glucose tolerance test. If you remember back to basic physiology, you know that glucose actually suppresses the level of growth hormone. So what you do is, just like diabetes, you give a big oral glucose load, and then you measure the growth hormone level. And if the growth hormone level is suppressed by that oral glucose, that's an appropriate response. Therefore, they're probably normal. If it's not, then it probably means they're either producing so much that it can't be suppressed, or that the systems that are in place aren't responding to normal physiology. So that's likely to be disease, and that's acromegaly. In terms of treatment, unlike with prolactinomas, surgery is usually the best thing to do for these people. If surgery is unsuccessful or not appropriate because of a patient's comorbidities, remember they get lots of diabetes, which isn't good for surgery, lots of heart disease, that's not good for surgery, all of this kind of stuff, then you can do radiotherapy and use somatostatin analogs and stuff like that, but they're not as good as surgery. Okay. Now, this one I'm not going to talk a lot about now because we'll go on to this when we do steroids. This is an adenoma that secretes not prolactin, not growth hormone, but ACTH. Now, ACTH causes lots of cortisol to be produced by the adrenal glands and causes Cushing's syndrome. And I'm sure you're all aware that when you get Cushing's syndrome in association with the pituitary adenoma secreting ACTH, that's the time you call it Cushing's disease. That's an absolute favorite of examiners everywhere. So what will you get? The features of Cushing's, characteristic electrolyte disturbance, this kind of stuff, and this, and which I'm going to talk all about later, how you differentiate all the different types of Cushingoid syndromes. Okay, so that's what happens when you have too much in the pituitary, too much going on, too many hormones being produced. On the other hand, sometimes you can get a situation where the pituitary is not functioning properly in terms of the hormones it's producing. And usually this is partial. So it's never just the case, unless you've ripped out the pituitary through surgery or you've irradiated the whole thing, that all of the hormones aren't secreted. Panhypopituitarism is very rare. But there can be partial deficits, often in association, say, with a macroadenoma that is only influencing some cells in the pituitary rather than all of them. And the causes are an adenoma, so usually a macroadenoma greater than 3 centimeters. Metastases, you can get, unfortunately, cerebral metastases to the pituitary. Iatrogenic, so that we've already alluded. Oh God, what have I done? Oh, there we go. That I've already alluded to earlier. That's your surgery, transvenoidal surgery, or your irradiation. Head injuries can cause them, severe head injuries. And then this one, another one, absolute favorite, postpartum ischemic necrosis or Sheehan's syndrome, which you'll see maybe once in your medical lives, but we'll hear about 50 times more in your exams. So that's the anterior pituitary. Posterior pituitary, you've got your 2 hormones, your ADH, which is all about water, and your oxytocin, which has to do with lactation and childbirth and that sort of thing. We're not going to talk about oxytocin, but I do just want to mention diabetes insipidus, which is the main problem that occurs when you have a mess up in that ADH mechanism. So, as I'm sure you are aware, there's 2 types of diabetes insipidus. There's the cranial one, where the ADH is not being produced at all or not being produced enough. And there's the kidney one, or nephrogenic diabetes insipidus, where for some reason the kidneys just don't respond to that ADH that's produced, and they don't affect what that ADH wants them to do. Helpfully, most of the causes of cranial diabetes insipidus are as the ones we saw back here. Predictably, I mean, it's called diabetes, polyuria, polydipsia. And because they lose lots and lots of water, they also get a hyponatremia. So those are the sort of 3 features. But if I were you, I'd just remember polyuria, polydipsia, because it's diabetes. No glucose. Insipidus means bitter. No glucose in the urine because it isn't diabetes mellitus. So it's going to be polyuria, polydipsia with no glucose in the urine. For EMQs and stuff, that is the sort of process I would go through in your mind. You diagnose it through a water deprivation test. This is a really, really complicated test to carry out. It has to happen over a number of days and involves collecting litres and litres of urine and measuring sodiums and all sorts of things. I've never done it, but the thing you need to understand about it is what it's basically doing. You're depriving the patient of water, and you're measuring the ability of the kidneys to concentrate the urine. And obviously, if you haven't got much ADH, then you're going to have difficulty concentrating your urine. So the test will be positive. If pituitary in origin, then what you do is you give an ADH replacement, which is desmopressin. And it's usually delivered intranasally. You can give it orally, but usually it's done intranasally. Obviously, if someone's got nephrogenic diabetes insipidus, this is not going to work, because you can give them all the ADH in the world, but their kidneys just aren't going to respond to it. Okay. Once again, we're doing steroid hormone disorders now. Now, these are the ones that people really get confused about. All of the sort of high DEXA tests, low DEXA tests, ACTH, all of this kind of stuff. Steroid hormone disorders. Once again, you need to know a little bit about physiology. You need to know that the adrenal glands have 3 bits. They have a capsule on the outside, which doesn't do anything really. You have the cortex, 80%, the medulla, 20%. In that cortex, you have 3 important bits, the glomerulosa, fasciculata, and reticularis. Those aren't really important to know, but you just need to know the cortex produces mainly these 3 classes of hormones. So aldosterone, cortisol, and the androgens. And then your medulla is responsible for adrenaline, so noradrenaline and adrenaline. So once again, Endocrinology is easy in essence. If there's a problem with the hormones, you can have too much or you can have too little. So if we talk about the cortex, we've got those 3 sets of hormones. For each of those, you can have too many of them and you can have too little of them. So if you've got too much glucocorticoids, you get Cushing syndrome. Not Cushing's disease, Cushing syndrome. I made my point. Too much aldosterone, you get Con syndrome. Too many androgens, you get these horrendously complicated virilization syndromes. So, glucocorticoid excess. As a phenomenon, though, not all glucocorticoids necessarily have their disease basis in the cortex. Obviously, that's where they're produced, but only these two, actually only this one, adrenal tumor or hyperplasia, within that cortex can cause too many glucocorticoids to be produced. In fact, what's more common is for one of the other things to happen. So you could have exogenous sources, such as patients who are on high-dose steroids, perhaps for immunosuppression purposes, perhaps even because they take lots of steroids through an inhaler for chronic lung disease, perhaps. You can have ectopic production of steroids. There are some nasty lung tumors and tumors elsewhere that can produce steroids autonomously. And then, as we discussed before, you can have Cushing's disease, which is where there's a pituitary adenoma that secretes lots of ACTH, which then brings out its effect on the cortex to produce lots of steroids. So, Cushing's is one of those things where you have to have the sort of features on the tip of your tongue, rather like hypothyroidism, hyperthyroidism, Cushing's, that kind of thing. You need to be able to go, aha, you get these sort of features. So I'm not going to go through them in detail, but moon face, thin skin, easy bruising, centripetal obesity, proximal myopathy, striae, buffalo hump, all of these things should be hopefully fairly familiar to you as the features of someone who's got too many steroids on board. These we've already discussed. So, someone we think might have Cushing syndrome. We might think that because they've got all those features. We might think it because they have a characteristic disturbance such as this. Okay. Now, sodiums and potassiums. I'm going to talk in the second half this afternoon about sodiums and potassiums. But this particular combination here of hypokalemia and hypernatremia, if you ever see that in an EMQ, if you ever see that in real life, you have to think about steroid excess, because that's a very, very common pattern to see for this condition. So we can't just say, because someone is fat and has a bit of easy bruising and is a bit hypertensive, that they necessarily have Cushing's. We have to actually say, well, has this person got lots of cortisol on board? And then once we've established they've got lots of cortisol, we need to establish why. What's of those 4 underlying causes, which one is it most likely to be? So we start simply, and what I want you to do is try and remember the bolded ones on each side. Okay, so we start very simply by just measuring the level. And there are a number of ways to do this, but the one that has shown the best evidence is a midnight plasma cortisol. And this is because through natural circadian rhythm, the level of cortisol is at its lowest at about midnight in most people. So if you take a plasma cortisol, from all of you, hopefully in this room, it would be at a very low level, but someone with Cushing's who's producing lots of steroids or has lots of steroids on board, it's high. You can also do the low-dose dexamethasone test, which I'll talk about in a second. You will have heard of these as well. These aren't as good as this, but they essentially do the same thing. They quantify the amount of cortisol. And then you need to decide what's the cause. Someone's got all these steroids, but is it because they've got a Cushing's disease, a tumor in their head? Is it because they're taking steroids themselves? Is it because they've got an ectopic source? Or is it because they've got an adrenal tumor or hyperplasia? And that's when you use plasma ACTH and the high-dose dexamethasone suppression test. So just try and group those things in your head into those 2 groups. So let's start with ACTH. This is a bit where sort of homeostasis makes sense. If you know the pathway of pituitary, ACTH, adrenals, steroids, then you can sort of figure this out. If there's a pituitary adenoma causing Cushing syndrome, then it must be that that adenoma is producing ACTH. So you measure it in the blood, it's going to be high. Once again, ectopic source, okay? Ectopics tend to produce ACTH-like compounds. Actually, they're not. Tumours and things in the lung don't actually produce ACTH, but they produce various para sort of proteins that have ACTH-like structure and therefore cause stimulation of the adrenals to produce steroids. But they do show up on the test, helpfully, as ACTH. Now, if the ACTH is low, then it's being suppressed. Normal homeostasis, negative feedback. If it's low, the steroids must be coming from somewhere else. It's not the ACTH causing that person to be hypertensive and fat. It's just because they have got too much cortisol being produced by the adrenals, or they're taking lots of steroids. So that's a very simple way to think about ACTH. And the DEXA tests now. So the first DEXA test is the 1 milligram DEXA test, and that's really easy. You send them home with 1 milligram of dexamethasone, they take it at midnight, they come back in the morning, and they have their cortisol measured. If the cortisol is low, less than 50, I don't think you have to know the level, but if it's low, then they don't have Cushing's. They just don't have it. The high dose one is used to distinguish the cause. So in this one, it's a bit more complicated. You give them 2 milligrams, 6 hourly, for 2 days, having measured the cortisol just before you gave the first tablet and at the end of the 48-hour period. With a pituitary adenoma, or in Cushing's disease, the level of cortisol is suppressed. Because if you bombard a pituitary adenoma with enough cortisol, you can actually stimulate that negative feedback mechanism. It can be done. But with an ectopic, such as a lung tumor producing ACTH, you cannot. No matter how much steroids you throw at the thing, it will not reduce its ACTH secretion. Okay, so is everyone clear on that? Low, high DEXA test, ACTH. Once you have a sort of basic understanding of how the tests work, it's a lot easier to figure out what they do. Everyone happy? So we've done glucocorticoids. In the cortex, we now come to the mineralocorticoids. Now, these ones cause, once again, hypertension. Importantly, mineralocorticoid excess, or CON syndrome, is a really important cause of secondary hypertension, and hypokalemia. They tend not, however, to cause sodium retention. So while in Cushing's you've got hypokalemia and hypernatremia, in CONS you only get hypokalemia, usually only get hypokalemia. Now, causes of this, primary, so you can have an adenoma or bilateral hyperplasia of the gland producing too much renin, or importantly saying something like heart failure, or anything where you've got increased secondary activation of the renin-angiotensin-aldosterone system. You can also get a sort of pseudo-CONS type syndrome because the renin is being appropriately stimulated by some physiological process. CONS is relatively rare, so I don't want to spend a long time on that. These things, however, are much more common in real life, common in exams. Hypofunction of the adrenal cortex. Now, this affects most of the lines of the hormones, so both mineralocorticoids, glucocorticoids, and the sex steroids. And you can basically have two situations. You can have an acute insufficiency, where there is a sudden total loss of adrenal cortical function, or you can have a much more chronic insufficiency, which is often called Addison's disease, where you get gradual, slow destruction of the adrenal cortex. Acute insufficiency is a medical emergency. It's very difficult to diagnose because it does happen, but not happen enough that we always think about it. But it causes a very sort of classical set of things to go wrong, which can basically be explained by the fact that if you suddenly knock out all of the steroids that you have available, then you can't maintain your blood pressure properly. So you get, that shouldn't really be hypovolemia, it should be sort of hypotension, I guess. You get very low blood pressure, you get very low glucose, because glucocorticoids are one of the things that help to maintain euglycemia. And you get, this classical thing now in reverse. So notice before, in Cushing syndrome, we had hypokalemia and hypernatremia. Now, when we have the reverse, we get hyperkalemia and hyponatremia. So just remember, try and remember that distinction. If you ever see sort of one, the sodium's low or high, the potassium's the opposite, always think about an endocrine cause. What can cause this? Well, very, very severe sepsis. Some of you might have heard of disseminated intravascular coagulation, that kind of thing. That sort of level of sepsis can just completely shut off your adrenals. Decompensated Addison's disease, this is actually probably the most common situation. And this happens when somebody who has known Addison's disease, that's chronic adrenal insufficiency, they get an infection or an acute stressor, and they don't increase the amount of steroids they're taking. So they have a sort of relative acute insufficiency. And then finally, this is the one that can also happen in patients who are on long-term steroids, and they have to be long-term, so greater than 2 or 3 weeks. If they suddenly stop them, then they actually get an acute insufficiency such as this, because they just can't cope with normal stressors because they're so dependent on those steroids. And yes, it's serious and it can be fatal. Chronic insufficiency is another one of those things like a prolactinoma in a postmenopausal woman or a man, which is sort of very iffy, very difficult to diagnose. They get fatigue, weakness, anorexia, weight loss, dizziness, depression, abdominal symptoms. Most of the patients I see in A&E seem to have all of these things, but they don't have Addison's disease. But for your exam, these features are the ones you need to look out for. These are the sort of words that if you see, think, this could be Addison's. Hyperpigmentation. The reason they get that is they have lots and lots of ACTH floating around trying to stimulate their adrenals to produce steroids. And one of the breakdown products of that is a substance called POMC, which can be laid down in the skin and cause hyperpigmentation, particularly in the palmar creases. They get postural hypotension for the reason that when you move from sitting to standing, there are various physiological mechanisms that are required to make you have a sustained blood pressure so that you keep the blood supply to your head and you don't fall down. And one of those involves production of glucocorticoids. If you don't have enough glucocorticoids, you will get postural hypotension. And as with all of these conditions, associated other immune-type conditions. I haven't spoken about the causes yet, but one of the main causes of Addison's, and certainly in the Western world, is autoimmune disease. So vitiligo, another autoimmune diseases hunt in packs. So watch out for the patient with thyroid disease, the patient with type 1 diabetes who presents with this kind of thing, because they may have another autoimmune process such as this. Diagnosis, can measure the cortisol. And it can be low, but like most of these first-line tests, this one's quite cheap, but it doesn't pick up all cases. The gold standard is this one, so short synactin test. Same principle, it's a provocation hormonal test. You measure the levels at time 0, you give something, in this case ACTH, and you see what happens. With a normal adrenals, if you gave some ACTH and the feedback mechanism was intact and working, you'd expect cortisol to go up at 30 and 60 minutes. But if it's not working because it's not there, say in Addison's disease, then it won't. Simple. Finally, these ones, I'm not going to spend a long time on these. I'm not sure. They don't feature that heavily in your syllabus, but just be aware there are syndromes with androgen excess. These are called virilizing syndromes. The most common ones are these ones, congenital adrenal hyperplasias, that are caused by various different mutations in different hydroxylase, usually enzymes at the various stages of steroidogenesis, and they all cause roughly the same sort of virilizing type syndromes. If it's not caused by this, so in adults, then it tends to be more carcinoma than adenoma. This is one of the rare the rare situations in endocrinology where hormonal abnormalities are caused by tumors. Most of the time, hormonal abnormalities seem to be caused by adenomas more than carcinomas, but here, carcinoma is more common than adenoma. So we've done the cortex, the medulla. So the pheochromocytomas, everybody knows about these. Really easy. They're another cause of secondary hypertension, to add to your list. They produce catecholamines, adrenaline, noradrenaline, cause episodes, usually of headache, severe hypertension, anxiety. They can cause hot flushes, all that kind of stuff. And they have this rule of tens. So 10% have associated with this MEN too. I'm not going to talk about MENs, but there is these multiple endocrine neoplastic syndromes which you can get. 10% of them bilateral, 10% are malignant, and 10% are extrarenal. That's a very sort of useless sort of thing to know, but there it is. To diagnose it, 24-hour urine collection is absolutely the gold standard, and you look for this VMA, which is one of the breakdown products of catecholamines, and it will be in high concentration in the urine. Obviously, you want to look for the cause. 90% of the time, it will be in the adrenals alone. So your first thing you do is you CT the adrenals. Treatment is mainly surgical. You've got this thing, it's secreting lots of adrenaline. Adrenaline is bad because it gives you a stroke, it will give you hypertension, it will muck up your heart. So you need to take it out. However, you don't take it out immediately until you've got their blood pressure and things under control, because that would be obviously a disaster before an anesthetic. So you give them this drug, phenoxybenzamine, which tends to reduce the blood pressure and buys you time to then go and do the surgery. Fine. How am I doing on time? Oh, gosh, good. Plenty of time. Fine. So those are the basics. I mean, the main thing to remember with pituitary, Cushing's, all of that kind of stuff is know the normal physiology, know how the basic feedback systems work, and try and figure it out rather than learn it. Try and think, okay, why is the ACTH high? Why is the ACTH low? If there are lots of steroids, in this situation, would I expect that to be that? You don't necessarily need to sit down and learn, the characteristic clinical features of Cushing's syndrome are hypoglycaemia, try and actually figure it out. The more logical you make it, and this is something I try and get across when I lecture, when I do podcasts and everything, is the more logical you make it, not only will it be easier to remember, but also when you actually come to start working, you're much more able to apply those principles to novel situations that you don't know anything about, because you're just used to that system. You're used to figuring things out from relatively basic principles. So, diabetes. Diabetes is something that is unbelievably common. All of those conditions you'll probably see once or twice as a house officer. This you will see every single day. So that's also important as well. Try and have some perspective. I know that exams aren't real life, sort of, but when you actually come to working in the clinical environment, this is the kind of thing you really, really need to know, and you really need to know well. So try and have a bit of perspective on that when you're revising as well, in terms of topics that you really need to know and topics that you don't. But diabetes is definitely one that you really, really need to know. This table I learn once every 6 months, and then I immediately forget. It is the WHO diabetes criteria, with lots of 7s, 8s, 11s, and my girlfriend tried to explain to me the other day some easy way to remember it. It's called magic numbers of 7, 8, 11, and 9 or something, but it's not very obvious. Basically, you've got 2 ways of diagnosing diabetes or all its other syndromes. You can do a fasting glucose, and you can do an oral glucose tolerance test. Okay. The fasting glucose, the magic sort of figure that I always remember, I always forget the 6.1, I just remember the 7. So if I think a patient may be diabetic, then I arrange for them to have a fasting blood glucose. They eat nothing from 8 in the evening, and then they come in 8 in the morning and they do a blood glucose. It has to be a plasma glucose, not a finger prick glucose. And if their blood glucose is greater than 7, then they are diabetic. It's very easy. Now, if their blood sugar is less than 7, but greater than 6.1, then they may have some sort of impairment in glucose tolerance. Now, there's lots of different types of impairment. There's impaired fasting glucose and impaired glucose tolerance, but I sort of put them into one thing. So they're not normoglycemic, they're not diabetic, but they're in this middle ground group who may be at risk of developing diabetes in the future. It's just like, for example, pregnant women who get a bit of diabetes during pregnancy are later in life much more likely then to go on to develop diabetes. And that's what happens in this group here. And in this group here, this is when you really start doing your oral glucose tolerance test, which is basically where you give them a big load of Lucozade, a couple of glucose tablets. 2 hours later, you measure their glucose. And if it's greater than 7.8, we call that impaired glucose tolerance. If it's less than 7.8, then actually that's absolutely fine, but their fasting wasn't so good, so we call that impaired fasting glucose. Okay. That's the sort of way to approach this problem, rather than just learning the table, because the table, just looking at it like that, doesn't really make sense. But if you start at one point, so if you start with the clinical question, I want to know whether my patient is diabetic, then you're much more likely to understand and to actually remember the significance of the test that you're doing and these numbers. So this will all be very familiar to you, but just to go through it very quickly again, type 1 diabetes is autoimmune attack on beta cells. You kill off your beta cells, you get an absolute deficiency of insulin. This happens mostly in young people. The more we know about diabetes, the more we find out that actually it can happen at many different ages. I saw someone a couple of weeks ago who was 45 years old and was diagnosed with DKA, new onset type 1 diabetic. So it's not only your 15 to 20-year-olds who get it, but for your exams it mostly will be. Clinical presentation is easy: polyuria, polydipsia, weight loss. Anyone know why they get weight loss? Hyperglycemia? Hypoglycemia. They wouldn't have hypoglycemia. Not yet, anyway. Yeah, so they urinate lots of glucose, so they're losing lots of glucose, but they're effectively starving. That's why they get weight loss, because there's plenty of glucose everywhere. It's all swimming around their bloodstream, but it can't go anywhere. Without insulin, the glucose can't go anywhere. The insulin is like a key which allows glucose to move from the bloodstream into the cells where it can actually be metabolized and used for ADP and ATP and all that stuff. So they get weight loss. The other reason they get weight loss is because they haven't got any energy. So what they do is they break down fat. And the problem with breaking down lots and lots of fat very quickly is you get byproducts called ketones. Now, ketones are okay. They provide some level of fuel for the brain, for the heart. But if you keep living off ketones, your blood goes acidic. You get acidosis. So for example, if any of you in the room who are not diabetic went out and had a bender, if we measured your urine in the morning, there probably would be ketones in your urine, but you haven't got acidosis and you're not diabetic. It's just because you haven't had enough to eat and you've got alcohol on board, etc., and you get a bit of ketones produced. But the emergency in diabetes is ketones and acidosis. So you get so many ketones from breaking down so much fat because you have absolutely no glucose that you get acidosis in the blood. The treatment is simple replacement insulin. And how do you replace it? There are lots and lots of different ways of doing this. Type 1 diabetics either have injections or they have pumps. The pump is meant to sort of stimulate the effect of the pancreas externally. So they have a little pump that sits here, they have a tube that goes into their abdomen, and they just, before each meal, they type in the amount of insulin they want to take, and it just gets infused straight into the abdomen. And there are some very clever new ones that also have glucose sensors built in as well, so they can get a continuous view of what their glucose is and then adjust it. The other group are on various insulin regimes, injectable insulin regimes, basically based around two systems. One, which tries to replicate the function of the pancreas absolutely, and the pancreas does this thing where it produces a very low background level of insulin constantly, and then whenever you eat, there are little spikes, and that's called basal bolus. And then there's an analog mix regime as well, where you mix a short and long-acting insulin together and give it as 2 injections to try and get a smoother insulin profile as possible. Okay, so that's type 1 diabetes in a nutshell. Type 2 diabetes, you've got two basic problems. The fundamental problem is not because you've got a whole load of inappropriate immune cells deciding to attack the pancreas. The real problem is because, for some reason, the cells that normally respond to insulin to allow glucose to go from the blood into the cells stop responding to it. And because of that, you have a state of hyperglycemia in the blood. Over time, however, what happens is, as you've still got the hypoglycemia, the pancreas really, really struggles. It sees that glucose and it goes, I want to produce more and more and more and more insulin. So it keeps pumping out insulin until it exhausts itself. So often many years into diabetes, type 2 diabetics often almost become type 1 diabetics because their pancreas becomes so worn out from producing so much insulin. As you know, type 2 diabetes tends to affect an older population, once again. Not entirely true, as we see much higher rates of obesity now in younger people, and is also associated with this thing called the metabolic syndrome. So that's being obese, having high blood lipids, having hypertension, and having high blood sugar. The clinical presentation is very, very different to type 1 diabetes. It's very slow in onset. In fact, 50% of people with type 2 diabetes in this country are walking around not knowing that they have type 2 diabetes because the onset is so slow. It can, however, present as an emergency, which I'll talk about in a moment. And treatment is just like hypertension. It's a sort of lifestyle first, so adjust your diet, less sugary things, then try some tablets, then eventually, often when this insulin deficiency bit is set in, insulin has to be started. Now, I don't know how much you have to know about pharmacology, but if you want a sort of quick sort of guide or rough guide to how you treat type 2 diabetes, obviously you start with lifestyle. Lifestyle doesn't really tend to work for this group of patients, so invariably they get started on a tablet of some sort. Now, actually, this is getting simpler and simpler as the years go on, but essentially the distinction is made between fat type 2 diabetics and thin type 2 diabetics. If you're a fat type 2 diabetic with a BMI greater than 25, we usually start metformin. If you're a skinny type 2 diabetic, BMI less than 25, you get started on a sulfonylurea. Different drugs work in different ways, but that's the criteria for how you start them. If for some reason you're not successful with that drug, you just add in the one that you didn't start. So if you started metformin, you add in that one, the sulfonylurea. If you have started on the sulfonylurea, you add in metformin. Now, if that doesn't work, very, very occasionally they will add in, hospital consultants will add in other sort of complicated PPAR gamma antagonists and all sorts of things, but most people just then go straight onto insulin. Okay. So for your purposes, I would just think, divide it: fat, thin, metformin, sulfonylurea, and insulin. Those are the things that are available to you for treating diabetes. Now, complications of diabetes. This is really, really important. There are 3 complications in each big section. Diabetes either has problems with or causes problems with big vessels, macrovascular, that's easy, that's cardiovascular disease, cerebrovascular disease, peripheral vascular disease, and associated ulcers. Microvascular is your problems with your eyes, your problems with your kidneys, and your problems with your nerves. Okay. So nephropathy, many type 2 diabetics, much more than type 1 diabetics actually end up being dependent on dialysis because they get large amounts of damage, often then with a superimposed nephropathy, such as IgA nephropathy or something, which pushes them into renal failure and they require dialysis. Retinopathy, very, very common. Massive cause. I mean, a lot of people in the UK who are blind because of late diagnosed or poorly controlled type 2 diabetes, and neuropathy as well. So the glove and stocking type neuropathy, diabetes, #1 cause. So, a bit more interactive, a bit more fun. Pictures now, pictures. pictures are your friends when it comes to revising. Certainly when it comes to clinical things. One of the best things that you can do, rather than looking at pictures in any of the big medical textbooks, is to get together with a group of friends. Each person brings a couple of pictures, and you go around the room and you just talk about the picture. Because the key thing you need to be able to do in your clinicals, whether it be in OSCE, whether it be PATES, is to be able to talk in a medical fashion that people, that other medical professionals can understand and describe things in that sort of way. So I would encourage you to you can Google anything, just put in ECG and just take one picture and go, okay, you present this ECG. And the next thing, you just show a picture of somebody, say with acromegaly, and you go, oh, this person looks like they've got macromegaly, they've got frontal bossing, they've got their hands across their chest, they've probably got diabetes, I could diagnose this using whatever. You see where I'm going. So, anyone? ST elevation, yes. In lead 2, 3, and 2, 3 AVF, and over here as well. 2, 3 and AVF is a inferior myocardial infarction. Okay? For some reason, every single ECG you ever see in an exam is always an inferior myocardial infarction, because they love to see the fact that you can say that it's in 2, 3 and AVF. Therefore, it's inferior. Okay? Now, the reason I put this up is actually this ECG was taken from a man who came in because he felt a bit unwell, a bit sweaty, and was diabetic. Diabetes can cause silent MIs. So, as well as getting neuropathy, I'm sure this isn't how it actually happens, but it's the way I think of it. As well as getting neuropathy in your hands and your feet, you also get neuropathy in your heart. So if you're having a massive heart attack, you don't actually feel it. You just feel unwell otherwise. And diabetics do present this way. So they just present unwell. You do an ECG, bingo, ST elevation, they've had a heart attack. And this is really tricky. Anyone? Yes, cotton wool spots. Anyone know what these are? Those are called hard exudates. And is this normal, all this stuff? No, those are new vessels. Okay. The 3 big features for diabetic eye disease: cotton wool spots, hard exudates, and new vessel formation. Cotton wool spots basically represent focal areas of ischemia, because that's what happens with the retinopathy. The high glucose levels causes ischemia to certain areas of the retina. Hard exudates are cholesterol deposits within the eye. Diabetes often associated with metabolic syndrome, high cholesterol deposits in the eye. And new vessels form as a response to ischemia in the eye. So when you have not a lot of oxygen in the eye, you get lots of secretion of various growth compounds that cause these vessels to grow. Now, if the vessels grow and grow and grow, this type of vessel is very, very fragile, so it tends to burst. And that's the thing that causes the diabetics to lose their sight. They get all these vessels growing, they're very fragile, slight trauma to the eye, and the vessels burst and they go blind in that eye, and there's nothing that can be done. This one. Yes, ulcers. These are probably, and I say probably because it's difficult to tell, but they're probably neuropathic ulcers. And diabetes in the feet is a massive, massive topic. You could spend a whole hour talking about diabetes in the feet, but basically the issue comes from the fact that in the feet in diabetics, you get both problems with the vasculature, because of that macrovascular peripheral vascular disease bit I spoke about, but also because of the neuropathy. Because diabetic patients, they don't have normal sensation, particularly of proprioception in their feet. And because they don't have normal sensation of proprioception, they tend to put lots of abnormal stresses on their feet that cause this kind of thing. And for example, these ones, and if ever you see one of these, they're described usually as punched out ulcers. This would be described as bilateral punched out ulcers over the head of the second and third metatarsals. They're probably anesthetic, so if you touched them, the patient wouldn't feel a thing. You could go right into that with a needle and they wouldn't feel a thing because of their neuropathy. But this is characteristic site for neuropathic ulcers. And then this, does anyone know what this is? Oh, fantastic. Yes, this is the Charcot joint. This is the other thing that they get in their feet as a result of not being able to sense or have good proprioception. And because they don't put the right stresses on their feet and their muscles don't move in the right way, they tend to get huge amounts of disruption of their foot architecture, often with its associated infections and things like that as well. So this is the Charcot joint, and a lot of these patients actually end up having amputations. Okay, so that's basically type 1 and type 2 diabetes. Things that come up a lot are the acute complications of diabetes. We've spoken about the chronic ones, but the acute ones are very important, particularly this one, hypoglycemia, and the acute type 1, other type 1 condition, which is hyperglycemia, particularly DKA. So in hypoglycemia, the glucose is low, obvious, I hope. And it usually occurs in patients with diabetes who are on insulin, either because they've taken too much insulin or because they've taken their dose of insulin and haven't eaten enough or anything like that. And they tend to get two different types of effects. One entitled sympathetic mediated effects, which basically is like being nervous, fight and flight. Blood sugar gets low, the body tries everything to try and kick off some adrenaline, kick off some glucocorticoids to try and raise it up, and associated with that you get your fight and flight type response. And then the other thing that can be quite confusing is the centrally mediated effects. Okay? And that's why in any patient who comes in who is slightly off, out of sorts, out of colour, then one of the most important things to do is a glucose. That's why some people, you've all heard of ABC, airway, breathing, circulation. Some people say that you should say ABC and then D, E, F, G. Don't ever forget glucose, because all of these things that aren't necessarily associated with hypoglycemia can be a manifestation of it. I put this up not because I want to, I know you're just doing your intermediate MB. I'm not trying to, push things too far, but I want to just bring in the concept of a way of approaching treatment for anything. Whenever anybody asks you about the treatment of anything, there is an approach to take. Now, often it's not the most appropriate thing to do. So you're in a general practice and a man comes in and says he's got a sore shoulder. The GP turns to you and says, what are you going to do? You're not going to go, I'd start by resuscitating the patient with respect to their airway, breathing, and circulation. But from an exam perspective, you show that you're safe by doing that. And also, from a learning perspective, the more you get used to using systems like this, the easier over time you will find it to actually learn these things. So whenever you're learning the management of anything, the treatment of anything, always at the very top write A, B, C, and maybe a little arrow off saying what the important components of that particular of A, B, C would be in this case. Okay? So here, someone asked me the question, how do you treat someone with hypoglycemia? I go, I resuscitate the patient with respect to their airway, breathing, and circulation. Particularly, I'm interested in securing their airway, because if they're comatose, they're not going to be able to maintain airway. Their tongue could fall back and they could choke. Breathing, they might not be able to breathe. I'll just give them some oxygen. Circulation, I want to assess their circulation. I want to put a line in so I could give them some treatment, so IV access. And then when it comes to treatment, it's not so important, but you can either give them treatment by mouth, so just glucose, and I guess that makes sense, low blood sugar, give them some glucose, or you can give treatments intravenously, so intravenous dextrose, or glucagon, which helps to mobilize glucose stores from the liver. Okay. So the next one we come to Ketoacidosis, diabetic ketoacidosis. Diabetic ketoacidosis is really, really easy because it's all in the title. The person's got to be diabetic, so they've got to have glucose in their urine or be known to be diabetic or whatever. And they've got to have ketoacidosis, so they've got to have ketones, which is, remember, that breakdown product of all those fats and things in their blood. They've got to have an acidosis, which I'm not sure if you would have done interpretation of arterial blood gas, but pH is usually 7.35 to 7.45, and we say less than 7.3 is an acidosis. And usually they should have a good trigger. So this could be a first presentation of type 1 diabetes. It could be because of an infection. An infection, remember your fight or flight diabetics, they get a big glucocorticoid response. They're not taking enough insulin, and they get into problems with this. Non-compliance, perhaps they're not taking the medication. That's very common in teenage diabetics. And as I said before, perhaps they've had something even more serious that you're not picking up on, silent MI perhaps, or a stroke. What are the clinical features? Very obvious: polyuria, polydipsia, dehydration, weight loss, just like the presentation of diabetes. They have this particular type of breathing called Kussmaul breathing, a hyperventilation, because what they're trying to do is to compensate through a respiratory mechanism for that acidosis to try and blow off excess CO2, because CO2 is acidic. They get vomiting because they're unwell, and they can eventually go into a coma. This is another situation where you should always, always, always have a system. Those of you who have listened to my podcast know that I have these 5 categories of investigations, 5 sort of modalities of investigation, which I think you should always use. If anybody ever asks you, or if you're writing notes and you want a sort of place to, or a scheme to put things in, rather than just writing the investigations for pneumonia, a chest x-ray, a urine dipstick, bloods, A and ABG, you should put it in a system, because then when you come across a new situation, you can just go, oh, I don't really know, but let me just think, could I do a urine? Actually, yeah, urine might be appropriate there because of this. Could I do bloods? Yeah, I could do bloods because their white cell may be raised. Or ABG, yeah, they might be decompensated and they might have a low oxygen level in their blood. Once you have a system, everything just fits into it, or you can make it fit in. You don't have to learn for every single disease a whole new set of things from scratch. So this is just an example of a system I've used. Urine investigations, yeah, we want to know what the urine shows. Ketones, is there any glucose there? Perhaps they have an infection, we could send it off for culture. Blood, arterial and venous. Always divide blood into arterial and venous. And ABG, absolutely, because we want to know what their pH is, because that's the definition. Venous, venous gas, don't worry so much about that. Full blood count, we always do a full blood count. U's and E's, they might be dehydrated, potassium, they might have an infection, the CRP. Blood cultures, they might have an infection. Other things, chest x-ray, they could have a pneumonia. Why would you do an ECG? Heart attack, silent MI, yeah. And treatment is exactly the same. How would you treat a patient with DKA? I would resuscitate them with respect to their airway, breathing, and circulation. And then I would rehydrate them, because they're going to be dehydrated, and I would put them on a sliding scale. That's it. If you said that in your finals, you'd pass. That's all, and that's all across the country. That is the standard that you need to be at and be able to talk in that way, logically and consistently. So airway, breathing, circulation, we've covered all of that. The basic principle of treating diabetic ketoacidosis is to rehydrate, first of all. People with DKA are really, really dehydrated, because just think about it. They've got glucose in their bloodstream. That glucose in their bloodstream causes a massive osmotic diffusion gradient, as we were talking about. All the fluid just pours into their bloodstream, and they just pee it straight out because their kidneys are overloaded. They just pee all of it out. They get very, very dehydrated. So the first thing that you do is you give them lots and lots of fluids intravenously. And then the next thing you do is do an insulin sliding scale. People get very scared of insulin sliding scales. All it is a sort of artificial pancreas. So you measure their glucose, and then you match that to the rate that the insulin goes in. So say someone's got a very high glucose up here at 16, you want lots of insulin. If someone's got a very low glucose, you don't want a lot of insulin. Note, however, that at the bottom end, even though the blood sugar is only 0 to 4, you always have some insulin going in. And that's because, as you'll remember from earlier, when I talked about the basal bolus regime with the 4 injections, the pancreas constantly produces a small amount of insulin all the time. And then if they've got, for example, infection, which has caused the DKA, you then want to treat that. Now, finally, type 2 diabetics have their own particular emergency called HONC, or hyperosmolar non-ketotic illness state coma. It's another acronym. But HONC, basically, this only happens in one situation that I've ever seen. It happens in either people who don't know they're diabetic or have a UTI and forget that they're diabetic. So what happens is they're sitting at home and they think, I'm feeling very thirsty. So they go to the fridge and they get a bottle of Lucozade. And they drink the bottle of Lucozade. And then, unsurprisingly, because of their diabetes, they are still very thirsty. So they drink another bottle of Lucozade, and so on, and so on, and so on. And the problem with doing that is actually they lose the ability to get rid of that glucose. So their blood gets so thick, so full of glucose, it almost becomes like treacle. It's so, so sweet. They get a blood glucose of 35. If you remember that we were diagnosing diabetes on the basis of a blood sugar greater than 7.1 or whatever it was, blood glucose of 35 is bloody high. They also get a very, very concentrated blood, so 340 milliosmoles. They don't, however, get acidosis or ketosis. But this thing comes with its own list of problems. Mainly that if it's severe enough, it causes coma. So if your blood gets that thick, you can't actually perfuse your brain properly, and you end up going into a coma. It also gives people DVTs and PEs. And most people who get this HONC end up dying of usually a DVT. If you just think about it, if you remember Virchow's triad with all the 3 different things, hypercoagulability, hyperviscosity is a real risk factor for DVT. But they get mainly polydipsia and these neurological signs because of this very thick blood. And it's treated with, as you'd expect, rehydration, insulin, and this is the one thing to remember about HONC. They have to have heparin. You know, all patients get who have surgery have heparin to prevent DVTs, that kind of thing, but these people get the kind of doses of heparin as if they already had a PE because they're so hypercoagulable that if they don't, they will clot. Right, I probably went on a bit long. So what we're going to do, we'll have a break now, coffee or something, and then afterwards I'm going to teach you a way of thinking about electrolytes that hopefully you will never forget. See you in a bit.